Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today some more important rules that hopefully will help you take care of your patient. Rule number 179. Don't be prepared, be over-prepared. So this is probably a good rule for life for many of us, depending on what you do for a living or just for a living. But in the pediatric emergency department or in medicine in general, I feel like it's always good to be prepared. And it's probably a good idea to be over-prepared. A good example is the sedations that I do in my shifts almost daily. So personally, I always use ketamine for sedation because most of the time when I sedate, it's a painful procedure. So I need analgesic, I need amnestic, I need a sedative. Sedation with ketamine is perfect for that. And I must say, with ketamine, I very, very rarely have any issues whatsoever. The patient is rarely hypoxic, there's rarely any apnea, the hypertension is totally fine, we don't really do anything about it. However, as we all know, sedation requires consent, and there's a reason for that. It is considered a high-risk procedure. Therefore, being prepared or being over-prepared is always a good idea. So how many times have I had to ventilate a child who got ketamine sedation? I have to say, never. However, I am always prepared with soap, suction, oxygen, airway, and pharmacy. So suction is always ready in the room, even though I rarely use it. Oxygen is always given by a nasal cannula, although it's rarely necessary. Airway devices such as the bag and mask, which thank God I've never had to use, are always ready in the room, appropriate size, etc. And pharmacy being the medications that I need. I gotta be honest, I never prepare any antidotes. I don't really have any antidotes for ketamine, but something that I always keep in mind, at least know the dose to know what to ask the nurse in case you need some flumazenil or Narcan or something like that. Another good example is when doing a procedure that is slightly invasive with some risk of bleeding. So all of us suture kids almost every day, on every shift. It's a very common procedure that we do, and usually it's on the face or the hand, areas that don't particularly bleed very much. However, when I am about to suture a child, beyond what comes in the suture tray, I always have another box or two of gauzes just in case I need to control some bleeding that I did not expect. Every time you evaluate a wound that was done by someone else, I think it's always good to be prepared for the worst with some kind of method for bleeding control, even though it's a very low-risk procedure, even though it's very unlikely to happen. Rule number 180. Let your trainees practice medicine. So this is something I personally feel very strongly about. Our trainees are in the emergency department, and unfortunately, like all of us in medicine, they spend a lot of time in front of the computer because they have to document. They often spend a lot of time talking to social work or consultants and not necessarily practice medicine. When I work with my trainees in the pediatric emergency medicine department, I try to remove all that busy administrative work from them so they can go see patients and practice medicine. A good idea is after sedation or after procedure that I do, there's often a big mess in the room. Depending on the procedure, there may be some sharps to clear, gauzes that are maybe soaked with blood that have to be thrown away, and I think the nurses often really appreciate it when you leave the room clean and they don't have to do it. When I finish the procedure with my trainee, I always ask them to go ahead and go see their next patient or go see whatever their patient needs in order to put some orders, but I don't want them spending 10 minutes in the room cleaning the room. That is something I can do so they can go and practice medicine, be doctors, and get their training. I don't see any reason for a trainee to do busy work or administrative work that I can do for them, especially if it takes away from their clinical time. Oftentimes, when I have a discussion with a trainee about a patient and the patient is ready to go, I volunteer to put the discharge instructions, print the discharge instructions, give it to the patient, again, just to take away from that work from them so they can go ahead and do their clinical duties. I think as it is these days, trainees don't spend enough time in front of the patients and unfortunately spend a lot of time in front of the computers. When I'm able to save them that time and have them spend more time in front of the patient or see another patient, I try to do exactly that. Rule number 181. buy time when you can. So one of the most important tools when evaluating patients that we pediatric emergency department physicians or clinicians often don't have is time. Many times patients just need to declare themselves, and what you see in front of your face right now is not necessarily the true clinical picture. So when I can, I try to buy time in order to hopefully do what's right for the patient. And again, as always, good idea to explain with an example. So a few weeks ago, I had a patient in the pediatric emergency department that I gave IM epi for anaphylaxis. I must admit the anaphylaxis wasn't particularly severe. The patient definitely had hives, and I thought I heard some wheezing on exam. I've said it in my podcast before, and I feel very strongly about it. We all know it's probably a good idea to err the side of caution and always give epinephrine for what you think is anaphylaxis. IM epi is very safe, very effective, and literally can save a life. So after evaluating the child, I saw that he had some hives. I heard mild, faint wheezing just once or twice. I decided to give IM epi. I observed the child, and about an hour and a half later, the patient started coughing. He wasn't coughing before. When I took a listen, he wasn't wheezing. His hives almost disappeared, but they were certainly still there. And I thought to myself, this could certainly be a rebound reaction. Maybe I need to give another IM epi. And giving another IM epi is by all means no big deal. It's not a particularly invasive procedure, not particularly expensive, not high risk or anything. But I thought to myself, perhaps I can just observe the child a little more. I'll go and listen to him again. If he starts wheezing, having respiratory distress, and especially if he has those with the hives that come back, or if they're still there, can most definitely give some IM epi later. By observing the child, I kind of guaranteed, in a way, that this is not a rebound reaction. He was just coughing for whatever reason. So always use time when you can. Don't jump into giving a treatment, admitting, etc. if you can buy some time in the emergency department and hopefully get a true clinical picture of what the patient has. Another good example, something that I try to do quite often in order to avoid CT, is admitting children with possible appendicitis for serial abdominal exam. I think that's a great example of simply buying time. So unfortunately, very often when I have a child that I think has appendicitis, the ultrasound doesn't see the appendix, the CBC is kind of in between, and the pediatric appendicitis score is smack in the middle. In those situations, yes, you can always get an abdominal CT with contrast and probably get a definitive answer. However, my favorite approach in those situations is calling the surgeon. If there's a resident in the ER, they can come and evaluate the patient, tell me what you think. But my personal preference is to admit those children for serial abdominal exam. Although appendicitis is considered a surgical emergency, we all know it's not exactly true. Patients certainly have many hours or even days before they actually need to go to the OR. Obviously, you want to do it as soon as possible, but if the patient is stable, well-appearing, pain is for the most part under control, my personal approach is to admit those kids for serial abdominal exam after getting approval from surgery, of course, and by doing so, I simply buy time. Why scanning every abdominal pain when the ultrasound doesn't see the appendix, which by the way happens pretty often unfortunately, as opposed to keeping the child in the hospital, have a pediatric surgeon and maybe a resident checking the child, and if he or she start developing signs of surgical abdomen, maybe take them to the OR, repeat the ultrasound, etc. But buying time often gives you the best picture of what's going on with the child. Unfortunately, it's not something we have in the emergency department all the time, so I try to utilize it when I can. And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you enjoyed the podcast. Hopefully you can check out my column on EP Monthly, check out the website. Please contribute to PEM Rules if you can, and please write back if you have any suggestion. If you want to come on the show and share an interesting patient you saw and you applied the rules, by all means, just let me know. Following outro is one of my favorite songs by one of my favorite bands, of course, from the 90s, Rage Against the Machine. This is song number 1 on their second album. It's called People of the Sun. Very tricky, very cool. Tom Morello is probably one of the best guitar players ever. Thank you again for listening. I hope you enjoyed the episode. Please continue to listen to PEM Rules and have a great day.